I covered it in Today in Health. It's just the article on state reimbursement. And you mentioned earlier, and so I just say that to tee up this question, which is, you said earlier, 50% of visits via telehealth and 25% of inpatient days at home. Is that right?
Yeah, perfect.
So that requires a business model change, right? And this is the thing we keep talking about, CIOs stepping into those business model changes. Most CIOs don't want to wade in there. They're like, well, that's not the business model. We're not ready to go there. Instead of saying, I think this is the future. Let's encourage this conversation. Like, I think we can do this with technology. And if we can do it with technology, I think somebody else can do it with technology. So at what point do we start to see business models change? And at what point are we a part of those conversations? And did you guys have those conversations?
Yeah, absolutely. And then that's what we're talking about when we talk about the CDO. Why are CDOs coming from other industries? And it kind of I'm glad, because we need to learn from other industries. At the same time, I'm like, come on, because if you want to be the CDO, they shouldn't have to get someone from outside, because you can do it. And so that's one of these areas where you have to lead. You have to be a business person. You have to be a clinical person. So don't be afraid. Don't say, well, I'm just IT, I'm operations. Well, then I wouldn't hire you as a CDO if that's the way you felt. So you got to be bold and take risks, even if it means you lose your job. So what? If you're good, you'll get picked up somewhere else. So you got to be bold. That's the worst thing, right? I know this isn't what you asked, but the worst thing is someone who just becomes assimilated. Like, they're bold, they get hired, they're so excited, and then they get pushed back and they decide to play it safe. And that's why healthcare is so far behind, because so many of us have played it safe over the years. So it's time for bold new leadership, whether it's outside or inside. So to answer your question, yes, of course. And so we really had to work through it. So I pushed our way through it, and we changed it. So what it was, I'll give you two really good examples. One was how physicians were compensated. So I can't get into the specifics to reveal sort of the magic sauce of where I came from, but there was a definite way that physicians were compensated. Productivity was analyzed carefully. So suddenly you're doing telemedicine visits, which at the time were not on parity in terms of reimbursement with an in-person visit. So how do you make that change? So what do you get with the chief of staff? You get with the CFO. You start laying out the arguments and why this is the future and why we have to go this way and why we have to make accommodations in that productivity formula. And that's what ended up happening. They made accommodations in the productivity formula so that you were not penalized for doing a telemedicine visit. That was number one. The second one, which I was not successful with, but I bet if I had another run at it today, I would be. And that is, why do we have urgent care? Why do we have urgent care clinics when we have virtual care capabilities? Why do people go to virtual care? Okay, you go to the ED ideally because your artery is wide open and you need something quick, life-saving. That is good. Virtual care not going to help you very much there. But urgent care, why do you go to urgent care? Because it's less costly than ED care. It's usually less wait, a little bit more convenient, and there's more locations typically. But that's exactly what virtual care is for. So I took that on, Bill. I wasn't successful, but I took it on. I said, look, we want to go to 50% of outpatient visits being virtual, but yet we're advertising and pushing our urgent care centers. We don't need urgent care centers. It's brick and mortar. It costs a lot of money to run those brick and mortar centers. And we can do about probably 95%. Because the argument is you can do about 85% of what happens in the ED, you can do it virtually, or what happens in an outpatient setting. So in urgent care, it's probably like 90%. Okay, so let's argue you're a clinician, I'm not. Let's just say it's 80%. Okay, whatever that number is, a high amount of the reasons you would go to urgent care can be done virtually. So don't have urgent care centers. Let people go to the ED that need to go to the ED, handle everything else with virtual care. I did not win that one because why? Urgent care makes a lot of money.